here once again by Dr. Iqbal Malik, one of our lead interventional consultants at the Hammersmith, together with the rest of our nursing and radiology and physiology support team. So we've got about an hour today, and this presentation is part of the Live from the Hammersmith series of presentations which we're covering, which go into all kinds of things, not just coronary physiology, but looking at some aspects of pacing, some TAVI procedures, and so on. And you can see that today's case we're going to be, as I said, focusing in on using the latest physiological techniques. So we're going to be focusing on today using IFR, and IFR with the IFR pullback functionality, and we're going to be using this to help us understand how these physiological pressure-based measurements can help us with ascertaining how good flow is down a patient's artery, and whether particularly there's an area which could potentially benefit from stenting. We're going to frame this in the context of studies such as the Syntex study, and then go on to look to see how it fits in the context of other clinical evidence that we have. So very much this is the ethos of the Live from the Hammersmith. So it's live cases framed around clinical evidence, technical practicalities, and hopefully, and most importantly, improving outcomes for patients. So if we move on, you'll see that in this, there's an ability here for you to become involved and interact with us. So there's a Google number you can just type into the Google speech and voice settings on the internet, and here's the number. At any stage, please just fire in a question, and the team here will do the best to kind of get them through to us in the lab. I gather in Europe there's another number which you've been given which will avoid having to dial an international call to the United States. So here's the case. It's an interesting case. It's a 59-year-old male with some exertional angina, class 2. He's got an end-stage renal failure. He's on dialysis, and has had extensive PCI in the past to the LAD, the circ, and the right coronary artery. And previously, in 2013, had an echo which showed good left ventricular function, but no ischemia at that time. And subsequently, his symptoms have really evolved. Now, he went on to have a coronary angiogram in a few weeks ago, or just before Christmas, and we've just repeated some of those pictures now, particularly as we're going to focus in on today in the left system. And we're going to show you some of those pictures, and I'm going to let Dr. Malik just talk us through firstly the recorded pictures from November, and then maybe we can have a look at some of the pictures we've taken today as well. So Iqbal, why don't you have a look at these?
Thanks very much, Justin. So I think we can see on the screen now a picture of the left coronary circulation. There's quite diffuse disease. Here's a renal patient after all, and this is a slightly subselective shot of the circumflex, which shows a diffuse pattern, but the proximal stent looks patent. So if we move to the next shot. Okay, in the spider view, you can see that there may or may not be something at the ostium of the LAD, and it's really quite difficult to image that area. On the right-hand panel, that possible stenosis is not really very evident, but you can see the diffuse pattern of disease in the mid-vessel. Now, it's unclear whether this was given with nitrates. I must say my routine practice is to give nitrates before angiography, but that isn't universally the case, and so this may or may not have been with nitrates, but the mid-vessel certainly looks diffusely diseased, and we want to be considering whether that might be a cause of his symptoms. And then if we look at the right, then you can see that again the stent's patent, it's proximal, and then there's rather diffuse disease, and on the right hand panel you can see the PLV branch, which is a rather small vessel, has the tight pinch in it. So if we were looking for a cause of angina, we've certainly found one there, but it looks a little bit too small for me to chase that, try and do intervention on it to try and improve outlook, certainly.
Yeah, well thanks Iqbal. So that really is a very, very important point Iqbal has mentioned there. We were looking to put stents nowadays into arteries which would give patients a true benefit from revascularization, and whereas maybe 10 or 15 years ago we'd put lots of very small stents into small branches, nowadays we tend not to do that. We tend to use the size of the vessel as a guide of what we're likely to stent, and then to assess whether the vessel is appropriate for stenting using physiology. And you can see on the slides here that the plan today is to, as Iqbal said, to assess the circumflex artery and to assess the LAD, and maybe using IVUS towards the end of the case as well if we have time to assess the proximal LAD. And what we're also going to be doing today is, as well as using the pressure wire, using static measurements, we're also going to be doing some of these pullback measurements using some of the very latest technologies to do just that. And these technologies are all without the need for administration of drugs such as adenosine. So let's move on with the slide deck here, and we're going to have a quick look at what we do in terms of preparing things and what we call as the ABCs of coronary physiology. So the first thing we need to do before we make any measurements is to make sure that the cath lab table, the hemodynamics here, are talking to the pressure wire console. So the PA pressures have to be equal. So we're just going to do this, a very simple procedure. So the first thing you'll see Iqbal doing now is just kind of opening the PA port to 0. So if you look at the hemodynamics, you'll see that the line here is almost at a 0 in terms of the aortic pressure. We'll then ask the technician just to normalise this on the console, and we're also going to normalise it on the pressure wire console as well. So just press the 0 PA button and hopefully have everything now in harmony. So everything where it says 0 on the hemo system, it's 0 on the pressure wire console. Okay. So that's great. So now we're ready from a PA normalisation perspective, and we move on to the next slide, and you can see that we're going to now move ahead and actually get ready to use the pressure wire. Here we're using for one of the Verata pressure wires. This is the latest generation of pressure wires, which has some fairly unique features to it, particularly advantageous if you want to do repeated measurements and do PCI over the wire, because it's got a unique connector on it, which is on a spring-based connector, which enables the wire to be easily connected and disconnected. So there are three main things we have to do with this wire in preparing it. So the first thing is obviously unpack it. Then the next thing you'll see is just to flush it, and Iqbal's very kindly passed me a saline syringe. I'm just going to flush this. I haven't exposed any of the electronics here open at the moment, because we know that can cause problems if you do get them wet. So first thing, I'm just going to flush that. That activates the sensor and really gets things moving. The next thing here, there's a number 2 on this door here, which I'm just going to essentially open, and I'm going to just pass this across now to our technician, who's just going to connect that in for me. Can you please connect that in, and we will assess on the pressure wire console whether that has been connected. So let's just connect that in. That's great. So it just takes a few seconds to recognise the wire, and that's great. So it's just say waiting for 0, and once that's in, this is an important bit here, because this is essentially now saying that the console knows where 0 is as a kind of standard here. Mm-hmm. Okay, so this basically now tells us, if we let's just focus in on the wire itself now, and the physiology can come off the screen. That'll be great. You can see that we've essentially got a wire which is ready to go, and the last thing we want to do is essentially going to just unpack this from the wire, and we're going to just effectively begin the next phase, which is to reshape the end of the wire so it's appropriate for physiology. So we've got a wire here which we've already essentially got up and running and working, and effectively I'm going to just hand this over to Dr. Malik while I carry on and just talk you through these various ABCs. So the next phase of things which he will be doing is a couple of things. If we see the slides once again, and just the first thing we're going to do is just going to just rest that down very just gently once again, and we're going to just make sure the transducer height is absolutely correct and flat. The next thing we're going to do is we're going to shape the tip of the wire, which you see Iqbal's done here, just by putting a very, very small bend on the wire. And the next thing we'll do after that is get ready to advance the wire. Now, in all of these situations where we're making pressure wire measurements, it's very, very important to ensure that we're introducing the wire into a vessel which has been adequately prepared. And you can see, if we move on now, that we routinely administer intracoronary nitrates, and Iqbal in this case has already given a nice bolus of intracoronary nitrates, and he did that up front when he gave some heparin, he gave some nitrates, and this prevents spasm when the wire goes down, and it also ensures that the epicardial artery is at its biggest that it possibly can be. Okay, so if we move on now, you'll see that we're getting near to the phase here where we're ready and prepared to make a measurement. But before this, we have a very, very important step, which is the normalization. Mm-hmm. So, but why don't we go ahead and introduce this wire? And
So this wire really behaves very much like an angioplasty wire would. It's not like one of the old pressure wires, which was rather stiff, and you wouldn't dream of using it as your stock wire. With this Verata wire, I think we're pretty close to just carrying on with angioplasty on this wire if we decided we wanted to proceed, rather than switching over to another. The talker is preloaded, and to normalize, obviously what we want to do is to get the tip of the wire down, and we'll see which of the vessels. So it's decided it wants to go down the LAD, so we might as well take the LAD, and we want to leave the more proximal part of it where the black becomes less black, as where the normalization is going to occur. And of course it's vital to do this without the talker in, if you want to be puritanical about it, and leave it in the main stem. So I've got a roadmap on my screen which tells me that I'm in the ostium of the main stem rather than going any further down. I think if we were desperate to be sure, then we could always give a small puff of dye, but I think we're in a very stable position.
Can I ask you, before we make a normalization here, do you think there's any chance here that we could be, due to the angle of the guide catheter, just be damping the LTIC signal a little bit?
Okay, so I think that's a very good point, because what we can see is a great dichrotic notch, and I think the dichrotic notch is a great marker that we probably haven't got very much pressure damping. It's a rather short left main stem, so manipulating the guide catheter to try and get it to align is going to be slightly challenging, and it may fall out altogether. We considered whether an EBU4, this is an EBU 3.5, would be any better, but I suspect it would have the same sort of problem. It's just the main stem's very short. So I think it's a very legitimate point to make, and I'm very careful about looking at the aortic pressure signal with that dichrotic notch really telling me that I don't think there is pressure damping.
Okay, so we've got a good dichrotic notch, which is very, very important. So perhaps we could go ahead and normalise now. And I think what Iqbal's raised is a very, very important point, as you see from that slide, is that it's very, very easy to have a ratio, which essentially is 1, with effectively a very damp signal. And what we're looking for is the nice high fidelity signals where you see all the bumps on the pressure tray. So you see the dichrotic notch, you see the anachrotic notch, you see the nice pressure decline. If you don't see that, you really need to think what's going on. So could we normalise? Oh, thanks very much.
So Justin, while that's happening, let me ask you a question. Imagine those two signals were pretty much overlaying themselves anyway. Would you still bother to normalise?
Well, you should always normalise, and that's particularly the case with IFR. With IFR, you need to make sure you normalise both the pressures, so the PA and PD signal should be the same, but also make sure that any time delay has been normalised, because we know that if the two signals are out of phase, this can lead to error. Okay, so it's very simple. All you do is press the button, as you saw there. It takes a few seconds. Okay. So I know the plan here was to probably firstly take on the circumflex, if that's easy to get the wire down there. Yeah. And then whilst doing that, well, perhaps we'll watch you do that, and then we'll break off and have a little bit of discussion about why we do any of these measurements in the cath lab. So essentially we're looking to, there we go. So it's
okay. Little test for me, just to make sure that is circumflex. Yep. Okay. So you can maybe see that this is behaving like an angioplasty wire. In the pressure wires of old, that very acute bend would have had the guide catheter out, and I think this is really behaving very much like an angioplasty wire would. We can appreciate the stent, and this is really without a great deal of effort. I hope I don't jinx it. Without a great deal of effort, wandering down. And just a little test again, just to make sure I'm in the main branch.
So I have to say, I was wondering to myself then that if you were actually going to have to take that back and put a little bit more bend on that wire, but it seemed to go down.
Little test again. I think it's trying to find that other branch. Okay, so I'll come back a little bit further. Okay. It's wanting to take that little branch, which is interesting, isn't it?
So while Iqbal's doing that, let's just move on to if you talk around the topic. He's going to be working away. We can come back whenever he's ready for us, and really talk about why I believe everyone should be using physiology in their routine clinical practice in the cath lab. And this is ever more present now in 2015, really to it's ever been in the cath lab, but we've got even more evidence than before. Now, why do we need to do this? Well, if you take this image you see on the screen here, so this is effectively an angiogram image, and we fire X-ray beams through this artery here. Let's move to the next slide there. You'll see that if we look in this plane, the artery looks very tight, but if we fire the X-ray beams from another plane, it looks much more moderate. And you can see that it's impossible with our eye, and this is using a 3D OCT reconstruction that we did here at Imperial, that as we fly through this vessel, you can see how on earth can an angiogram image ever tell us all the contours and all the precise changes and bends and stenoses and atheroma burden which may exist in this vessel. Of course it can't. So you need to use an imaging modality such as IFR, such as OCT, and of course the thing which integrates all of these probably best is using a pressure wire. Now if we move on, we can see that using the pressure wire essentially enables us to differentiate flow which is normal but just within a smooth stenosis, which you see at the top, and one from a kind of craggy disease vessel at the bottom. Now why this is important is both of these two arteries have the same MLA, so the MLA is the same, but the one at the bottom has a significantly bigger pressure drop. Now moving on, you'll see that people have tried to try and see if they can get ever higher degrees of fidelity using IVUS, using higher resolution IVUS, using OCT, trying to match that with FFR. And you see whatever they try and do, particularly using a single measure such as MLA, trying to match it with FFR is very difficult. And if we move on, you'll see that, of course, the thing we are really trying to measure here is blood flow. And maybe this video will play for us. You'll see as we play, or perhaps it won't today, but the video essentially shows us that these are small little cells moving through, very, very small micro channels within the myocardium. And you can see all of the surrogates that we're trying to measure are essentially related to blood flow. So all these pressure changes we try and measure are essentially related to flow. And the reason we do this is because if we try and measure flow, and you can see this here, flow is very, very difficult to measure. And the first part of this cycle, you can see this is a flow recording which is inadequate. Second portion, you see the flow recording there is very, very good. It's using the same wire just by making small manipulations. But what is immediately obvious is that the pressure signals, so the PA and PD signals above it, are very, very similar and in keeping with one another. So that's great. So Iqbal, in that time you've managed to kind of get the wire down there. And if we can see the physiology traces on the screen, this may give us some information about what's actually going on, and perhaps you've got a situation here whereby the wire is just up against a little part of there we go, look at that. So what did you do there to make the difference there?
So basically, I'm sure it was up against the side wall. We're fairly far down. There's been quite a few bends in the vessel, and I think whenever I see that, all I'm doing is moving the wire back just a fraction. So centralize it in the lumen rather than it smacking against the side wall of the artery, and that's all it's taken. It's taken about 5 millimeters of pullback. I was well beyond the lesion of interest anyway. Okay, good.
So I mean, this always looked a little, very intermediate in terms of this lesion. We can see here that you know, this has got indeed a very, very intermediate stenosis with a resting gradient here of, you know, 1.02. Now, sometimes people ask why or how could you get a resting gradient which was above 1, and that's quite easy to explain. In the circumflex artery wraps around, and actually often the wire will end up in a position which is above where the transducer is sitting itself. And so this is a pure result of just atmospheric pressure and the fact that the center is in a location which is slightly lower than the actual pressure wire itself. Now in these cases here you can see the chance of this becoming positive is almost zero.
It's zero.
It's zero.
I think it's always worthwhile to pull back and make sure that the pressures are fine at the ostium again. And I think that's what I would do next, unless there's something else that we want to do.
I think we should do that, but let's just flush when we get back. Let's just check the pressure pressure drift first, and then then we can flush it and see.
So we're going to just pull this wire back and just put it back into the left main stem, which is where we centered before. And there we are. We're in the mouth of the main stem again now. Hopefully you saw that pullback. And so we can now just check on the pressure screen again.
So there we go. So there's no drift here. Again, you'll just the sensor's banging against the catheter there itself. So maybe we can just move that back in a tiny bit, so you just stabilise the signal.
There we go.
So there we go. So there's no drift here at all. It's gone back to 1. This is a brilliant example, I think, of just a phenomenon of physics. It's nothing to do with the wire drifting, and that's why the value's gone above 1. It's got nothing to do with the fact that the catheter wasn't flushed. This is purely a result of the fact the sensor was sitting above the transducer, and invariably it was above the pressure was higher than the actual transducer pressure that we normally measure. So that's great. It's a couple of good learning points there, and I think we're very happy here that this artery is normal. So next, if I can leave you just to kind of get on with the LED. I know there's a little bit challenging the LED, so I'll let you get on with that. And while we're doing that, we're going to just carry on talking and discussing about fractional flow reserve, really, because fractional flow reserve came from the first experimentation with trying to measure flow using a pressure wire, and this was developed, of course, by the pioneers in the field, Nico Pils and Bernard de Bruyn, and some of their seminal work came out in the early 90s, firstly, of course, with animals, and then moving on with humans. And you can see with the human data, as we know from their original deferred studies, moving on to the FAME and FAME2 studies, is very, very powerful and very, very strong in terms of helping to illustrate to us that physiology, over and above angiography on its own, is an important guide and diagnostic tool for improving clinical outcomes for our patients. So essentially, it makes us select stents more appropriately and is more cost effective, with an end result of better outcomes and lower clinical event rate for our patients. Now, we've got all of this evidence, but to me this is a staggering graph, because we see that despite evidence which is rife, people are only using these techniques around the world in a very few number of cases. And this is from a diagnostic perspective, so this is a number of times a pressure wire is pulled out and used in assessment during a diagnostic angiogram case, and you can see that the numbers here are very, very low. Hotspots, the United States, Western Europe and Japan, but a lot of the rest of the world, the numbers of wires being used, at least in 2013 and 14, was low. I think these numbers are increasing, but you can still see they're somewhat lower than you'd expect from the level of evidence that we have to date. So if we move on, one of the things which we tried to do a few years ago was to try and see if we could improve adoption by simplifying the technique. So we know in whatever walk of life we work in, if we make things simple and easy and reliable, then people adopt them and they move to them. And that was the purpose of the first IFR studies, and this was the ADVISE study. And essentially it was to develop a clinical tool which used a pressure wire with a sensor on it, exactly the same as you use for routine FFR measurements, which was sufficiently sensitive to identify whether a stenosis was necessary for benefiting from receiving a stent. And that's essentially what we did. So if you compare the different ways that we could assess arteries, and we move on to the next slide, you'll see that the IFR divides the distal and aortic pressure much in the same way as FFR does, but it restricts it to a portion of the cardiac cycle, so just a little bit of the window where resistance is lower and flow velocity is higher. And of course we know that what we're trying to achieve when we measure the FFR or the IFR is we try and use pressure as a surrogate for flow, and to do that we need resistance to be stable. And you can see on this slide, as we advance it on, that if the resistance is stable and constant, then pressure is proportionate to flow. Now, how do we make this stable in practice? Well, there's two main ways. The first is we can give a big slug of a very, very powerful vasodilator, such as adenosine, ATP, papaverin, whatever drug you give from different locations all around the world. And you can see what this primarily does is it reduces resistance in systole. So there's a very, very wide systolic dynamic range of resistance. As you can see, the phasic resistance moving up on the bottom panel here. And then when we give the drug, it reduces the resistance primarily in systole, and as a result the flow rises and the pressures fall. Now IFR does this by a different means completely. It uses a mathematical algorithm which makes these measurements at rest by identifying a phase in the cardiac cycle. This is the wave-through period, so it's in a portion of diastole where resistance is intrinsically stable and a great place to make measurements of physiology. So, Iqbal, how have you got on there?
Yep, so we managed to get the wire into the proximal part of the LAD. Yep. I think it's always good to now, because we've had a few minutes, give some more nitrates, yep. Normalize the pressure. So let's give the nitrates.
Great. Okay. So you seem to me pretty dogmatic in terms of your use of nitrates, your attention to detail with repeat normalization. Is this because you see lots of drift, or just because you know that this is the best way of making physiology measurements?
I think that unless you are meticulous, then it's rubbish in, rubbish out. So if you actually make measurements which are hurried, you don't understand the physiological basis of them, then you can't interpret the result. And so, you know, occasionally wires will drift. You need to understand that, and you need to know the clinical background of the patient. So I think we mustn't always forget the patient. So the patient needs to be linked in with the physiology to make the final decision, because there's no black and white in medicine, it's all grey. But I think you help yourself by being meticulous at every stage. So again, we've checked the guide catheter position, we checked for the dichrotic notch. He's nicely asleep, this patient, so the swing you're getting is a respiratory swing as he snores. And I've got a wire, which I don't know whether you can see the angiogram. The wire is parked inside the tip of the wire is inside the proximal stent. But the key to it is that the measuring part of the wire, which is at the end of the black part more proximally, is in the left main stem. It's before any stenosis. It's hovering in the main.
Okay, so essentially, to make quality physiology measurements, you need to ensure that you're rigid with your methodology. So always normalising, always giving nitrates, and essentially having a good understanding if you see a little bump on the pressure trace, or as we saw in that case that the value was higher than 1, to understand why it happens.
I think that's absolutely right, and also be able to troubleshoot the machine. If there's a shatter, I mean, luckily we've seen that shatter and see how easy it is to resolve as well, just by small movements of the wire.
Okay, good. So have you normalised this wire, or you haven't done that yet?
So no, we're just about to.
So you haven't normalised it, and it's still about 1. So so the wire really hasn't moved or drifted at all in this case here, but we're still going to normalise again.
I think so. I mean, whenever we move to a different vessel, I always normalise again.
Okay, good.
Okay.
That looks great. Okay,
and
so
just to make the point again, remember the needle introducers come back again. We're sticking with our same protocol. I know that our Korean colleagues have done some work which says that if you keep the needle introducer in the whole time, and you're not giving intracoronary adenosine, for example, then the readings are just as valid. But I think, because the world is getting used to using more physiology, let's do it the standard way and keep the needle introducer out.
If you standardise things, make the same measurements at the beginning and at the end and the middle, then you always make sure you have constant results there. So you're going to advance this wire down the vessel now, and perhaps we'll stay with you and see if this goes down nice and easily. Is there some stent in there already?
Yeah, so the proximal vessel is stented, and the stent looks wide open. I've got a road map on my screen to avoid giving too much contrast, and I'm just wiggling the wire. And as I say, I really enjoy using these wires, and if we need to stent, as I say, I will just use this stent. I use this wire to do the whole procedure, and of course that allows us to use the physiology afterwards as well.
So as you say, the wire is a very supple, steerable wire nowadays, and it's taking this little side branches as any kind of good wire would do, and but now you're kind of making good progress down there now.
Okay, that's fine. So I think we're well distal to any problem area. Again, I'm going to take the needle introducer back.
Okay, so a question we've been asked here is how far should you make the measurement of the physiology beyond the stenosis? Well, if you've got a discrete stenosis, and I think Iqbal's part this wire into a nice smoother segment of vessel, then you're fine. But ideally you want to be 2 to 3 diameter widths distal to the stenosis, to ideally ensure that the flow patterns have normalised once again. So 2 to 3 diameter widths of the vessel beyond where the stenosis you're measuring. But here we're clearly well outside that. So let's have a look at the physiology. This is the exciting moment. See what we've got here. And we've got the IFR. Now on this console, as David showing you, we've got the live IFR measurement, which is updated on a beat-by-beat basis, so 0.90, 0.89. So this looks to me like it's going to be a significant value, or we can see it's going to be significant here. And perhaps after we've made the measurement, we'll make the measurement now. The next thing we'll go to do is, we can see this is certainly right on that cusp. Let's make the measurement. Is perhaps we could consider making a pullback recording. So David, if we can go there, that would be great. So 0.89. Okay, so that's what the live measurement was telling us. Very simple, very quick, and so this is exactly at the cut point we're using as a result of analysis from 3,000 patients, which have shown that the best IFR cut point is 0.89. It's been used in the FDA labeling as a result of the ADVICE 2 study, which was first presented at TCT in 2013. So this is what we're essentially using. What we're going to go and do now is we're going to go ahead and to show you how we can use the pressure wire to make a pullback measurement very quickly and very, very simply and easily. So now this is only available on this console at the moment, but I gather it will be commercially available more widely in the next few weeks. So if we can go to the physiology screen once again, and what we're going to do now is we're going to just flick across to the IFR pullback mode. And when we do this, you'll see a dedicated pullback screen comes up. And all we're going to do now is Iqbal's going to just slowly withdraw the pressure wire, and he's going to start performing the pullbacks.
Okay, so I'm going to give you the fluoroscopy at the same time, and I'm going to do it very slowly, just by hand, and we're watching the screen very carefully. Where there looked to be a bit of a stenosis was around here, and then this part is after the stent, but in a normalish looking vessel. And here we are now going into the stent, and then we are going up to the top end and back into the left main stem.
Okay, good. So if we stop recording there, that's great. Okay, good. So as I said, this is state-of-the-art software, and you can see that what the software has actually done is it's detected a few beats there where you had an ectopic beat or a slightly longer beat, and it's put those little red crosses there. So it's just a way of us knowing whether this beat's completely, the machine's completely comfortable with this beat, or perhaps if it looks funny visually, perhaps we could repeat it. But I think that looks great. I think it's just the machine being very, very cautious in this setting. So what does this really tell us? So we see that the gradient goes essentially from the gradient here is about 10, so this is the IFR of 0.89, 0.90 we saw, and it goes all the way back up as we come up towards the ostium of the vessel. Now what we're looking for, and we sometimes see, is very, very big step-ups and very, very big jumps as we come up through the vessel. I don't think we really see that here. What do you...
I think this looks like exactly what we see on the angiogram. Could we possibly play the angiogram? Because I think what we see is a diffusely diseased vessel. So let's play the angiogram. So let's play the angiogram, okay, and so let's play the cranial view, please, the one that we road mapped, and move forward to, there we go, okay. So one can see on that view that it's a pretty diffuse disease segment. This is now with nitrates, so unlike the diagnostic pictures, and I think you can see at that sort of third diagonal, really, there may be a little bit of diffuse disease. At the second diagonal, it looks as though there may be a more of a pinch. But actually, this is where the physiology comes in. Your eye might be drawn to put a stent exactly where that second diagonal is and say, what a great job we've done. Well, I've got to say that this is a borderline IFR at the best of times, and what it shows on the pullback is diffuse disease. There hasn't been a jump spectacularly at that spot. It's been all the way through, and if we treat that one spot, yes, we may marginally improve the IFR, but we're giving a patient a stent, and I suspect this is not where the angina is coming from.
I think you may well be right, and I think this is where we're really moving. If we could perhaps go back to the pullback screen, that would be very helpful. Previously, we've advanced the field, I think, using physiology by essentially saying that we can identify vessels which would benefit from stenting. And I think where we're going now with techniques which make it very, very simple to do a pressure wire pullback. You saw Iqbal do it. There's no need to give long runs of drugs or anything like that. Comfortable for the patient, comfortable for the staff, easy to make these measurements, is we're not now just identifying vessels which are ischemic, but we're looking along the length of the vessel to see, is there a place where we could position a stent and we can make a sizable benefit for this patient. Now if you look at this pressure wire pullback, as you can see on the screen, you could see that at best we'd be getting a 0.02% 0.02 unit increase in IFR, so that would be taking it from 0.9 to 0.92. So a very, very small increase by putting a single stent in, and one really wonders how much good that would be doing. In fact, you saw the length that Iqbal made the pressure wire pullback over in this case here, and really to get the full benefit and to really get the patient back up to a near 1 value for this measurement would require you to put huge lengths of stenting.
I think that was 38 at least. Yeah.
Yeah, so another slide has just come up, and someone's been asking us about the ability to use pressure wire pullbacks to make these measurements. Perhaps we could see the slides associated with this, and how we can actually use these pressure wire measurements in a more meticulous way to make estimates of the likely improvement following PCI, just from these measurements now, even before we open a balloon or stent. So maybe we can see those slides. So you can see that often is the case. We have a value here where we have a stenosis which is effectively significant. So the vessel here has an IFR of 0.81, so it's very significant for IFR. The stenosis has got effectively an effect on that vessel of 0.1. So what that means is if we put a stent in that location, this would increase the IFR value from 0.81 to 0.91. So that would be a big difference, a much more sizable difference than any of the increases we just saw on that curve there. And what was happened, and Dr. Nidja has done a lot of work on this to explain why this happens. Essentially, we use the resting flow trace in IFR pullback to an advantage over its hyperemic cousin. So here we have a well-known relationship between flow and stenosis severity. So you see, as the stenosis becomes more severe, hyperemic flow falls. Okay, so you can see up to about 50%. If you give maximum adenosine dose, you measure flow, the stenosis is increasing from 0 to 50, the flow is maintained. But as the flow as the stenosis increases from 50 to 100%, you can see there's a fall away. So flow decreases as the stenosis increases. Now, what does this mean? Let's have an example here of an artery here which has got 2 stenoses in it. Okay, so 2 moderate stenoses in it. You make your measurement distally, and you can see that the flow is abnormally low. It's far lower than it would be if there was no stenosis. And then what do you go and do? You put a stent in proximally, and then what happens to that flow? Because you've removed some of the obstruction to flow, the flow increases. Okay, so now if we go on, you can see that the flow's increased just by putting a single stent in there. Now, if we were to leave our pressure wire down distal to that last stenosis, with the increase in flow, and remember it's the increase in flow which determines the severity of the FFR measurement, the FFR may be the same, or it may even be worse because the flow has actually increased. Now, how does that differ from IFR? Now, IFRs are very, very different, and again, this is a well-recognized pattern of rest flow. So you can see across a wide range of stenosis grades, so 0 to about 90%, rest flow is preserved. So it's very, very similar across this whole range of values. Now, if we were to stent in exactly the same way using IFR, and then remeasure the flow afterwards, you can see the flow does increase, but it increases by a very, very small proportion. And this small change in flow is much, much more than that we see with the hyperemic cousin and measurements with FFR. Now, what's the knock-on effect to this, and what can we actually do with this? You can see that a study which was recently published now in JACC, it's just come out, JACC Cardiovascular Intervention, again this is work from Dr. Nidja, showed that when we systematically assess this, so essentially what we did is we did a pressure wire pullback just like you saw today, and then the vessel was stented, and we predicted what the likely improvement would be in the vessel after putting a stent in for a given size over a given anatomical area. And then we went back down with the pressure wire after the stent went in and remeasured the IFR. So in this, you can see the predicted IFR is 0.94, and the actual observed IFR which we measured is 0.93. So these two are extremely close and very, 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 very good from a clinical perspective to enable and help us to be able to likely predict the likely outcome prior to ballooning or stenting. And you can see in this case here today, we've really had to think twice about whether we should be putting a stent in at all, even though that IFR value, and I suspect strongly that the FFR value would be significant in this case. Now, if we can now look at the slides to see where we may be going with all of this, and I think this is really where the exciting areas are, so particularly with regards to co-registration. Now, co-registration, if you haven't seen it, is the ability to be able to merge and fuse different modalities together with one another. So you can see here we've got the fusion of firstly IVUS with anatomy. So this is very simple. Just like you saw Iqbal performing the pressure wire pullback, we pull back the IVUS catheter down the length of the vessel, and as we pull it back, the computer tracks the location of the IVUS catheter and cross-references each cross-sectional area with a location on the vessel, and it records that. So what that enables you to do after is it enables you to go back and forward down the vessel and looking at each location on the angiogram what the cross-sectional area is. So it's very helpful for IVUS. Now, what we're doing now, we're developing this from an engineering perspective, is essentially we're tracking not the pressure wire but the IVUS catheter itself. So we know what we're tracking the pressure wire itself, so we know at each location along the vessel what the IFR value will be. Now, what we can do if we have the location along the vessel and we have its length, we can start to work out the gradient and the rate of pressure loss along the vessel. And in the graphical representation here, you can see there's a very, very nice simple visual display of an artery. Now this perhaps could be an artery similar to we saw today, maybe slightly different here, and the real difference here is you can see there's areas of diffuse disease where you see just the odd single red dot interspersed with areas there where you see much more focal disease. So you see there's that area in the middle, an area more proximal, which is more focal. Now what we will be able to do shortly is essentially insert a virtual stent over that area, just slide it in like on an iPad interface with a finger, maybe insert one, maybe insert two, and then look to see what the knock-on effect will be of the IFR value in the distal vessel. So this is potential here to really help us, I think, in the cath lab, not only know which vessel to be treating, but also to know whereabouts we should be treating in the artery. Because the other thing which came out of Dr. Nij's work is that by using this technique, it may be possible to minimize the length of stent, not just by selecting the right area, but by looking at the physiological lesion length, which may well give us some additional insight over and above the anatomical lesion length that we use currently.
I think the key with this case compared to that graphic is that that was a 0.6 IFR distally. So we have something big to gain by finding a spot to stent. Even if we stented long, we're still probably going to win. Whereas here, this is right in the grey zone, 0.89, 0.9. The gain is going to be marginal at best. And I suspect that PLV branch is probably causing his angina.
I think you may be right, and I think we just saw a beautiful slide on the board which demonstrates this once again. You see here a very, very heavily diseased vessel, and as Iqbal said, you've got an FFR, which is the blue dotted line, which is around 0.6. You've got an IFR, which is the red dotted line, which is again around 0.6 as well. And you see as you come through lesion 3, 2 and 1, whether you're measuring under hyperemic conditions with the FFR or the IFR under resting conditions, you can see these discrete step-ups here. Stenting any of those would likely have a significant effect on the overall IFR at the distal end of the vessel. Now this is a particularly useful slide as well because it shows us the added value of both measuring either FFR or IFR over just the whole cycle resting PDPA. And it's very evident just looking from right at time point 0, the beginning part of the curve, because what you get with both IFR and FFR is a much bigger dynamic range. And what do we mean by that? Well, you can clearly see here both the IFR and the FFR go from 0.6 to 1. The PDPA at rest goes here from about 0.75 to 1. So everything is very, very squashed up, and as a result it's very difficult here to see the discrete step-ups from the actual noise that you have. So from an engineering perspective, we call this is how we want to use a technique which has the best signal-to-noise ratio, and in that case from a resting value that would be the IFR technique. So in this case here today, what do you plan to do with this artery? Are you going to leave it alone?
So I think I'm tempted to not treat the middle of that vessel. Now, there was a question mark, if you recall at the start, about the ostium of the LAD. Now, clearly, functional significance of that ostium is highly unlikely. Yeah. There's an unusual anatomical appearance because it's a very short left main stem. And I think it costs us nothing to actually just IVUS the ostium and answer the question that the clinician who referred for this case actually also asked us to do. So, physiologically, this is not a vessel that I'm particularly keen on treating. I'll give the anatomical information about the ostium, but I'm not planning on treating that either because physiologically it's not significant. So, but we'll have a nice picture to have a look at.
So I'll let you get on with that and do the IVUS. And whilst we're in the middle of doing that, perhaps we can just talk about why we feel comfortable to use IFR in the lab today. And there are really 5 key validation studies which I'd just like to talk to you about. So these are studies which have been done by different groups from all around the world, including our own, Javier Escanada in Madrid, Spain, the groups from Holland, including Gang Peek's group, Niels van Rooyen's group, and now groups from the United States as well. So what you can clearly see with all of these studies, essentially what they look to do is compare IFR and FFR against another gold standard. So you can see whether in these first 2 studies you're using the IFR and FFR against the HSR index, which is a pressure flow based index. Many people consider this to be the true gold standard in coronary physiology. And you can see that there's no difference in the first study, Clarify study. They both got a very high level of accuracy. In the next study, which is analysis done by Niels Johnson, is in Texas, you can see again there's no statistical difference in favor of FFR. In actual fact, this study shows that the IFR had a slightly improved diagnostic accuracy. data from the Amsterdam Centre, so this is the Academic Medical Centre, Jan Peek Centre, showed that whether you're measuring resting pressure flow indexes, the resting pressure index IFR or FFR against nuclear spec, again, there's no difference and no systematic advantage to administering the adenosine. And then another data set, again from groups here, largely in Europe, demonstrated that there's a much better relationship between the resting pressure measurements, so the IFR measurements, than FFR when you compare them against flow. Okay, so flow, of course, under hyperemia. The resting values, of course, are measured under resting conditions, and you can see that the diagnostic categorization with regards to flow, and remember that's what we're trying to measure here, is better when you use the resting pressure index IFR than FFR. Now, one other striking thing about this data is that if you look at the flow data once again, you'll see that the most important difference here appears to be over this very important intermediate 0.6 to 0.9 range. So what one would expect, this would be an area here where IFR may be worse. In actually fact, the research to date, and this is from large numbers of patients, so over 200 patients, so pressure flow study, these are huge studies, shows that in actual fact the opposite. It shows that the IFR is very, very accurate over these areas. In actual fact, it's the FFR where the accuracy starts to diminish. Now, the last study I'll talk about, the fifth study here of these validation studies, is a study reported by Niels van Rooyen and Gustav Woord from the centre in the Netherlands. And this was, again, a very, very important study. This is the first study which looked at testing IFR and FFR against PET. Now, of course, if you remember back to 1997, you'll remember from papers from Bernard de Bruyne in Circulation that this was a key and pivotal motion for the foundation of FFR. Indeed, you know, much of the confidence that people gained for using FFR came around the fact that it had a strong relationship with PET flow. And what did Gustav Woord and the team at VU Medical find? Well, they found exactly the same. They found that both FFR and IFR agree closely with PET flow. And really important and strikingly, you can see that there's no difference. All right, remember that the FFR is measured under hyperemic conditions and the PET is measured under hyperemic conditions as well. So these are very, very important findings. Now, if we look ahead now, we look to see the studies which are being done on the back, of course, of the FDA approval. We see that one of the important studies being done, and there are 3 or 4 very, very important studies being carried out at the moment, is the defined FLAIR study. It's a study which is looking at using IFR or FFR, much in the same way as we do today, to make clinical decisions. So this is being performed by 55 of the leading physiology centres from all around the world. All the continents are involved with this, and essentially we're randomising patients with intermediate coronary disease who physicians feel they need the pressure wire to interrogate to see whether stenosis is significant or not, and then patients are randomised in a fully blinded manner. Okay, so they're blinded to the patient which arm they're in, and they're also blinded up to the follow-up groups, either to FFR using a single cut point or IFR using a single cut point. And the outcomes here are going to be hard clinical events. First, going to be reported events will be at 1 year, but of course we're going to be tracking them through the studies. Other endpoints, of course, which are very, very important for us nowadays with the hard economic times we have, is to look at cost effectiveness. So can we do these tests in a very safe and reliable way, which is key and important, but also saving time and other procedural costs which may be associated with hyperemic measurement. Now, if we go on, you'll see that these studies are being used by others. So this is the Sweetheart investigators. A similarly large study, defined FLAIR is 2,500. This is 2,000 patients testing much the same things as defined FLAIR. And the great thing about these 2 studies is we're going to be able to bring all the patient data together at the end to give us 4,500 patients, so probably about 7,500 lesions. The endpoints have been harmonised, so we're really going to have a huge amount of physiology data. And so it's not just these studies which are looking at this. We also are using these techniques in the Syntax 2 study. So this is a study led by Javier Escanado and Adrian Banning, and the chairman here is Patrick Sorois. Very similar to Syntax 1 study, but there's one key difference, is that we're using physiology, so this so-called hybrid IFR-FFR strategy, to diagnose which lesions are in need of treatment, getting modern drug-eluting stents, and then IVUS optimization. And this study has been surprising all of us. We often get cases of 3-vessel disease, which we put pressure wires down, and we frequently overturn the angiographic decisions. And these patients would, of course, routinely be sent to surgery and now just having a single stent in the LAD. and that's really it for them. So we know that these techniques are really starting to gain some maturity. They're very, very usable. Techniques such as IFR make this ever more so the case. You know, they're robust, they're reliable, they're very simple to perform, and enable us to use them in large clinical outcome studies. And importantly, if these studies show non-inferiority whether compared to FFR techniques, then it's very likely that they may well take over in the clinical field. So, Iqbal, you've got an IFR catheter down.
I've got an IFR catheter down. I thought I might demonstrate how easy it is to take the sensor on and off the wire. So if we can focus on my hands, then if we just get to my hands. Okay. So we'll just, there we go. Okay, so I'm just going to wait for the camera just to pan right in, because I think I want to demonstrate how this volcano wire can be attached and detached. So remember, in the packet it came like that and the wire was attached. I can slide and place the wire that I've just removed back in. There's a little catch as it gets to the end, and that's it. We're ready to use the wire again, and if we want to detach, which is what I did to get the IFR catheter in, it's there. So attach, attach, and detach. And again, the contacts were really very difficult before, but this is very easy. It's got 3 or 4 contacts on there, so we always get a good signal out of it.
Very good. So now I've just unfortunately heard that the satellite feed is going to be ending in a couple of minutes. So I think you carry on with that, and I'm just going to address some of the questions, because one of the abilities of making this very, very live and simple to do is to actually address some questions which you may have. And there's a couple of questions which are coming. One is saying, if we administering nitrates, how long should we wait before we make our measurements of IFR? So perhaps we could just see the IVUS image as well in a small box. That'd be great while we're just discussing. So how long do we wait when we're giving nitrates? Well, essentially we give the nitrates, and we wait typically for about 20 seconds. Now, the first thing which happens when you administer nitrates is you get a mild hyperemia. Same as you give contrast, same as you give heparin, anything down the vessel, that's what you get. This lasts 20 seconds. Then what you get after you administer the nitrates is you get an epicardial vasodilatation effect. And the knock-on effect here in the epicardial vasodilatation is to make the vessel bigger, and effectively the IFR FFR value will climb, so it will become more normal. The other question I've been asked here is about ECGs, and particularly with regards to IFR. Well, IFR at the moment does require an ECG, and essentially this is to make things very robust and very simple and very easy to use. However, what we're developing, and indeed some data will be presented at the SKY meeting, which is of course coming up in April and May of this year, is a new technique which effectively uses IFR but no longer requires the use of an ECG. So it makes things even simpler and even easier to use. So I called out the corner of my eye, there's some diffuse disease down the length of that vessel, but essentially the ostium bit.
The ostium has really no problem. It's wide open. The stent is absolutely beautiful, which shows stenting can work. But actually, the bit that looked very diffusely diseased on IFR looks just as diffusely diseased. There is no focal stenosis. Actually, it's not as calcified as I might have imagined in a renal patient, but I think everything fits together with the idea that this is a vessel we should probably be leaving alone.
Okay, great. Well, that's great. I mean, here we've seen the use of physiology backed up by the IVUS, and I think really a key thing here with the IVUS was the fact that we confirmed in an angiographically difficult takeoff that there was no tight stenosis at its ostium. So I think we're coming towards the end here, and I think the feed may cut off at any second. I would just like to close by thanking Iqbal, who's done a sterling job here driving the case today. Thank all of our nursing and radiology team. Thank the physiology team as well. And most importantly, thank you for sparing some of your time to join us today for this Live from the Hammersmith case. We hope that these cases are exciting and interesting and informative to watch, and we hope that you'll join us once again in the near future to explore some other interesting areas of coronary intervention. Thank you very much.